There are approximately 100 million Americans living with fatty liver disease right now. The majority of them do not know it, not because the disease is rare or exotic or difficult to diagnose, because it produces no pain, no obvious jaundice, no dramatic symptom that sends a person to the emergency room demanding answers. For years, sometimes for a decade or more, fatty liver accumulates, progresses, and begins the process of replacing functional liver tissue with fat and eventually fibrosis. While the person goes about their daily life completely unaware, their annual blood panel comes back with slightly elevated liver enzymes, and their doctor says, "Watch your diet, and we will recheck in a year." The liver continues to progress. The window for intervention quietly closes. What I want to give you today are 4 specific signs, not the dramatic symptoms of advanced liver disease that everyone knows about, but the quiet, easy to dismiss, seemingly unrelated signals that the liver sends during the years before imaging would show serious damage. Signs that most people are currently experiencing and attributing to aging, to stress, to diet, to everything except the organ that is actually producing them. And I want to give you the specific blood tests and imaging studies that can confirm or rule out fatty liver disease at a stage where lifestyle intervention is still fully effective, because at that stage, fatty liver is one of the most reversible serious diseases in medicine. I am Dr. Edward. What you are about to hear is educational information based on published scientific research. It is not a substitute for personalized medical care. Fatty liver disease exists on a spectrum from benign fat accumulation to cirrhosis and liver failure, and the management of each stage differs significantly. If you have diabetes, obesity, or a history of heavy alcohol use, you are in a higher risk category and should discuss liver screening with your doctor, regardless of whether you recognize any of the signs I am about to describe. Subscribe to this channel right now if you are not already. Every week, I cover the research that explains the symptoms your appointments run out of time to address. It is free and it takes 2 seconds. Subscribe and stay with me, because the 4 signs I am about to describe are present in millions of seniors right now, and almost none of them know what those signs mean. Let me start with the biology of why fatty liver produces no pain, because this is the question that most people ask first, and the answer explains why so many cases progress to advanced stages before anyone intervenes. The liver is a large, metabolically extraordinary organ, the largest internal organ in the body, processing everything you eat, drink, and inhale, performing over 500 distinct biochemical functions, filtering the entire blood supply multiple times per hour. It sits in the upper right abdomen, protected by the lower rib cage, and it has no pain receptors in its functional tissue. The liver parenchyma, the cells that do the actual work of filtering, metabolizing, and synthesizing, cannot feel pain. The only pain-sensitive structure associated with the liver is the fibrous membrane surrounding it. The liver produces pain only when it swells enough to stretch that membrane, which requires substantial organ enlargement. In early to moderate fatty liver disease, the stages where intervention is most effective, the liver does not swell enough to produce any detectable discomfort. This anatomical reality is the core of why fatty liver disease is so clinically dangerous. An organ performing critically important functions is being progressively damaged by fat accumulation, by the inflammation that fat accumulation triggers, by the oxidative stress that inflamed liver tissue generates, and eventually by the fibrosis that inflamed liver tissue progresses to. And none of this produces a signal that the person can feel. The damage accumulates in silence until the functional reserve of the liver is so depleted that the organ can no longer compensate, at which point the symptoms that emerge are not early warning signs. They are signs of advanced disease. The 4 signs I am going to describe are not pain signals. They are metabolic and biochemical signals, the downstream consequences of reduced liver function that appear in systems the liver supports throughout the body. They are signals that most doctors do not connect to the liver in a standard appointment because each one has multiple possible explanations. But together, as a pattern, they point toward a liver that is struggling under fat burden, and they appear years before the standard liver function tests become obviously abnormal. The first sign is persistent fatigue that is disproportionate to activity level and not resolved by rest. This is the most common symptom of non-alcoholic fatty liver disease and the most universally dismissed. The liver is the primary site of glycogen storage in the body. the stored form of glucose that provides fuel between meals and overnight. When liver cells become fatty and inflamed, their capacity to store and release glycogen efficiently is impaired. The result is a pattern of unstable cellular energy availability, not the consistent low energy of thyroid dysfunction, but a more variable pattern characterized by energy that drops sharply between meals, difficulty sustaining mental or physical effort for extended periods, and marked fatigue in the late morning and mid-afternoon when the liver would normally be releasing stored glycogen to maintain blood sugar. The liver also synthesizes most of the albumin that maintains blood protein pressure and transports hormones, medications, and nutrients through the bloodstream. Reduced albumin synthesis in early fatty liver produces a subtle but measurable drop in the efficiency of nutrient delivery to tissues throughout the body, contributing to a fatigue that feels systemic rather than localized. This pattern, mid-afternoon energy crashes, fatigue that is worse after meals rather than better, difficulty concentrating in sustained bursts, is sufficiently specific that several hepatology research groups have proposed it as a clinical screening indicator for fatty liver in the absence of other symptoms. The second sign is a vague sense of heaviness or fullness in the upper right abdomen. The liver has no pain receptors in its functional tissue, but in fatty liver disease, the expanded and metabolically stressed liver creates a pressure sensation that most patients describe not as pain, but as a persistent awareness of the area, a sense of heaviness after eating that feels different from ordinary post-meal satiety, and occasionally a mild aching that is worse when lying on the right side. This sign is frequently attributed to gallbladder problems, to gas, to irritable bowel syndrome, to anything other than the liver. There is a clinical distinction worth knowing. Gallbladder-related discomfort is typically more episodic, often triggered by fatty meals, and more likely to produce referred pain to the right shoulder blade. Liver-related fullness is more persistent, less clearly meal-triggered, and associated with the other systemic signs of liver dysfunction I am describing. If you have been attributing a persistent right upper abdominal heaviness to your gallbladder, and your gallbladder has been investigated and found to be normal, the liver, sitting directly above it, deserves the next investigation. Do not wait until after this video to subscribe. If you have been watching this channel and getting value from it, the subscribe button is how you make sure the next video finds you. It costs nothing. Tap it now. The third sign is a change in skin appearance. Specifically, 3 skin findings that are produced by reduced liver processing capacity and that most seniors attribute to aging or sun damage. The first is spider angiomata, small, spider-shaped collections of dilated blood vessels visible just beneath the skin surface, typically appearing on the chest, upper back, and face. Estrogen is metabolized by the liver, and when liver metabolism is impaired, estrogen accumulates and stimulates the dilation of superficial blood vessels. When spider angiomata appear in clusters, when they are appearing in new locations, or when they appear in men who have no obvious hormonal explanation, they are a recognized clinical sign of liver dysfunction and warrant investigation. The second skin finding is palmar erythema, a reddening of the palms of the hands, particularly at the fleshy pads at the base of the thumb and the little finger. Palmar erythema occurs through the same estrogen accumulation mechanism. It is often present for years before a person connects it to anything other than warmth or circulation, and it is listed in every hepatology textbook as a classical early clinical sign of liver disease. Many people have looked at their reddened palms and assumed it is a skin condition. In the context of any other sign on this list, it is worth mentioning to your doctor. The third skin finding is generalized itching without an obvious skin rash or allergic trigger. The liver produces bile salts that are excreted into the digestive system to aid in fat digestion. When liver cell function is impaired, bile salt metabolism is disrupted, and bile salts can accumulate in the bloodstream, depositing in the skin and stimulating itch receptors directly. The itching of liver-related pruritus is typically generalized rather than localized, is worse at night, does not respond well to antihistamines, and is not accompanied by an obvious skin rash. It is one of the most under-recognized symptoms of early to moderate liver dysfunction and is almost invariably attributed to dry skin or aging when it presents in seniors. The fourth sign is a subtle but progressive decline in mental sharpness, word-finding ability, and processing speed. The liver detoxifies ammonia, a byproduct of protein metabolism that is produced throughout the body and is highly toxic to brain tissue. A healthy liver converts virtually all ammonia to urea, which is then excreted by the kidneys. When liver function is impaired, ammonia clearance is less efficient. Blood ammonia levels rise, not necessarily to the levels seen in full hepatic encephalopathy, which is a medical emergency, but to subclinical levels that are measurably neurotoxic over time. Research published in the journal Hepatology has documented subclinical hepatic encephalopathy in patients with non-alcoholic fatty liver disease who had none of the classic signs of liver failure. These patients showed measurable impairments in attention, psychomotor speed, and working memory on neuropsychological testing despite appearing clinically normal in standard appointments. When their liver disease was treated, cognitive function improved. The cognitive changes were not aging, they were ammonia toxicity at subclinical levels, produced by a liver whose detoxification capacity was reduced by fat burden. This is the sign I think about most when I consider the scale of undiagnosed fatty liver disease in the senior population. Millions of seniors are currently accepting a gradual cognitive decline as an inevitable feature of aging. Declining mental sharpness, slower processing, more frequent word-finding failures, when at least a portion of that decline is being driven by subclinical ammonia accumulation from a liver working at reduced capacity, not because the brain is failing, because the filter is. Now let me give you the testing framework, because I want to be specific about what to request and in what order. The first-line blood tests for fatty liver screening are ALT and AST, alanine aminotransferase, and aspartate aminotransferase. These are liver enzymes that leak into the bloodstream when liver cells are damaged. They are included in the standard metabolic panel. The critical limitation in non-alcoholic fatty liver disease, ALT and AST can be normal or only minimally elevated even in the presence of significant fat accumulation and early fibrosis. A study published in Hepatology found that up to 30% of patients with histologically confirmed non-alcoholic steatohepatitis had normal ALT and AST at the time of liver biopsy. Normal liver enzymes do not exclude fatty liver disease. The more sensitive blood marker is GGT, gamma-glutamyl transferase. GGT rises earlier in fatty liver disease than ALT or AST and is more sensitive to the oxidative stress of early fat accumulation. A GGT above the upper limit of normal in the context of any of the four signs I described warrants further investigation, even if ALT and AST are normal. Ask your doctor to specifically comment on your GGT level at your next appointment. The most accessible imaging tool is a standard abdominal ultrasound. An ultrasound can detect hepatic steatosis when fat content exceeds approximately 20 to 30% of liver volume. It is non-invasive, inexpensive, and widely available. If your blood panel shows elevated GGT or borderline ALT in the context of the signs I described, an abdominal ultrasound is the appropriate next investigation to request. For staging the degree of fibrosis, the non-invasive alternative to liver biopsy is a vibration-controlled transient elastography scan, marketed under the brand name FibroScan. This technology uses ultrasound-based shear wave measurement to assess liver stiffness, which correlates directly with the degree of fibrosis. It can be performed in a gastroenterology office in minutes. If your ultrasound shows fatty changes, requesting a FibroScan from a gastroenterologist is the logical next step. I also want to give you the most important practical information in this video, which is what actually reverses early to moderate fatty liver disease, because the news here is considerably more encouraging than most people expect. Non-alcoholic fatty liver disease in its early to moderate stages, before significant fibrosis has developed, is one of the most responsive conditions to lifestyle intervention in all of medicine. A reduction in body weight of 7 to 10% achieved through sustained caloric restriction and increased physical activity reduces liver fat content measurably in imaging studies and normalizes liver enzymes in the majority of patients. You do not need to reach ideal body weight. A 7% reduction from current weight produces quantifiable liver improvement in controlled trials. This is reproducible across multiple research populations. Beyond weight loss, the specific dietary changes with the strongest evidence for fatty liver reversal are elimination of added sugars, and fructose-containing beverages including sodas and fruit juices. Because fructose is metabolized almost exclusively in the liver and drives hepatic fat accumulation directly, reduction of refined carbohydrates that produce chronic insulin elevation, which promotes hepatic fat storage, and increase in dietary fiber from vegetables and legumes. The Mediterranean dietary pattern has the strongest overall evidence base for fatty liver reversal among complete dietary frameworks, with multiple randomized controlled trials demonstrating liver fat reduction and enzyme normalization. Regular moderate-intensity aerobic exercise, at least 150 minutes per week of brisk walking, cycling, or swimming, has been shown to reduce liver fat independently of weight loss. The mechanism involves increased hepatic fatty acid oxidation and improved insulin sensitivity in liver tissue. Studies examining exercise without dietary change found meaningful reductions in liver fat content on MRI spectroscopy after 12 weeks of moderate aerobic activity in patients with non-alcoholic fatty liver disease. Now, if you have been watching for a while and you have not yet subscribed, I want to ask you directly, why not? This kind of research, specific, clinical, actionable, is what this channel produces every single week. Tap subscribe now. It is free and it ensures this keeps reaching you. Here is the summary of everything we covered. Fatty liver disease affects approximately 100 million Americans, and the vast majority of cases are asymptomatic until advanced stages because the liver has no pain receptors in its functional tissue. The 4 signs that appear in the years before imaging shows serious damage are persistent fatigue with mid-afternoon energy crashes and post-meal worsening caused by impaired glycogen metabolism, right upper quadrant heaviness or fullness that is more persistent and less episodic than gallbladder symptoms, skin changes including spider angiomata, palmar erythema, and generalized nocturnal itching produced by impaired estrogen metabolism and bile salt accumulation, and subtle cognitive changes in processing speed and word finding caused by subclinical ammonia accumulation from reduced detoxification capacity. The testing framework begins with ALT, AST, and GGT on a blood panel, progresses to abdominal ultrasound, and stages fibrosis with FibroScan if fat is confirmed. Normal liver enzymes do not exclude fatty liver. Early to moderate disease is highly reversible with 7 to 10% body weight reduction, Mediterranean dietary pattern, and 150 minutes weekly of moderate aerobic exercise. Please share this video. Fatty liver disease is currently one of the most common causes of liver failure in the developed world, and it is preventable and reversible in its early stages. The reason it progresses to advanced stages is not that treatment is unavailable. It is that the diagnosis is not made until the window for effective intervention has closed. Every person who watches this video and gets a liver panel and an ultrasound that catches early fatty liver disease is a case of cirrhosis that does not happen. Subscribe to this channel if you have not already. My next video covers the specific foods that the research shows actively support liver fat clearance and hepatocyte regeneration. The foods that belong in your diet if you have fatty liver or want to prevent it. Subscribe so that video finds you directly. I am Dr. Edward. Your liver is one of the most forgiving organs in the body when you catch it early enough. Catch it early. I will see you in the next one.